or mine. Oh, I see we've got the recording going. Okay, so yes, I'm Susan Murphy. I'm with Disability Rights Texas, and I fight for funding and community services and people's rights so they can live in the community of their choosing with supports and services rather than in an institutional setting or a congregate setting. Today I'm very excited to be able to visit with y'all. Thank you so much for having me. And in a minute, I will put on the presentation. I was so excited when Cindy told me that there were a lot of people that signed up, because I thought, oh my, when they see my my bio and see that I graduated from college 40 years ago, they're not going to join. Well, the advice I will say, and this is how I believe in it, it's never too early, it's never too late to advocate for yourself and others in your community. And I think once we are doing it, we're kind of lifers. I will share that my daughter Emily is 40, just turned 40, and she lives with me at home right now. She does get support through the LTSS Waiver Program, and we're very glad to have that. So thank you for joining and not being scared off by the bio. So, okay, I am going to share my screen. I hope this works. I think it will. We did a little test run. And I'm going to talk about kind of what home and community-based settings and the settings rule is, and what's happened and what hasn't happened, and how it contributes to self-determination. So as Cindy mentioned, I'm with Disability Rights Texas. I am privileged to get to be a paid advocate for people with disabilities. My title is Senior Policy Specialist. And so we advocate during and in between legislative sessions. If any of you follow the legislature, we're in a very interesting time this summer with a lot of advocacy going on. But my focus is primarily community services and healthcare. So today I will be talking about specifically the settings rule and where Texas is and how that supports self-determination. Okay, can y'all see what can you see? Can you see the little side thing where all my slides are? If you can, I'm going to change that to just show the slideshow. So hang on one second.
Yes, we can.
Okay, yeah, that's kind of boring. So let me get up to the slideshow. Okay, let's see. I know it's here. Give me 1 minute. Okay. It wants me to set up the slideshow. I already have it. Okay, here we go. That didn't change it.
You can just click on the button that says from beginning.
Yeah.
Oh, thank you for that technical support. Thank you very much. Okay, so next slide. I'm going to just say what do we mean when we say what are home and community-based services? And the acronym, just in case we needed another acronym, is HCBS. I want to distinguish, and y'all probably know, I see a lot of people who have a lot of information already, but in Texas, we have a program that's not called Home and Community Services. It's HCS. So this is different than that, although that program and our other Medicaid waiver programs are under the umbrella of what is now called Home and Community-Based Services. In the past, if you thought about long-term care, you probably thought about a nursing home, nursing facility. And then for a long time, the term long-term supports and services was used to distinguish from nursing facility care, and that was generally community supports and services. But now, the main term of art that's used at the federal level is home and community-based services. It means the same thing. A lot of times those are provided through Medicaid waiver programs, but Medicaid also provides some attendant services and things like that for people that are maybe still on the waiting list for Medicaid services. So it's an umbrella term. It's for long-term healthcare services and supports for people in their home and in their community. And it is an alternative to services in an institutional setting. The services enable people to live more independently and experience more self-determination on their daily lives, living in the communities that they choose. And when they have those services, they also have healthcare services to meet their medical needs that support with daily living activities, just if they need support with functional support needs, or things like managing their budget, things like that. But also, and most importantly, community integration. So you see my little picture up there of the Supreme Court. Well, you can tell that's an old picture. But back in the day, when this represented, it wasn't the exact same Supreme Court, but it's been a long time, back in 1999, there was a United States Supreme Court decision that was based on a couple of women in Georgia who were using Medicaid to pay for their supports and services in an institution. But they didn't want to be there. They wanted to be out. They wanted to wave goodbye to the institution and get their services in the community of their choosing. So it was good that we had the Americans with Disabilities Act, and based on some of the provisions in that for being able to have programs in the most integrated setting, these two women were able to win the right to have their services in the community, and they moved out of the institution and into the community. And it wasn't just people trying to get out of the community, out of an institutional setting. It is also applied to people who are at risk of being institutionalized that are not currently already admitted to an institution. So what happened a few years ago, and it seems like it's been a long time ago, but in March, the federal government put out some new guidelines for home and community-based services. And the intention was that for the Medicaid money that's dedicated to these home and community-based services, that it's used more fully to support people to have self-determination and choices in their life, and less so, and really excluding using those home and community services to support people in institutional settings. So, you know, anytime new money or new guidelines come along, it seems like, you know, a lot of different type of programs want to get on board and see if they can use that money, which is generally more flexible than the funding for institutional care. But the home and community-based services rules are an attempt to prevent that from happening and use these limited pots of money in all the states to actually support self-determination and integration into the community. Well, the first round, since these came to be in March of 2014, the intention originally was states would have 5 years to come up with a plan and to evaluate their programs and services and to decide if they needed to be amended so that people are really fully supported to engage in the general community and to have more choices about their daily lives. Well, none of the states were really quite there in terms of in 5 years being able to come into compliance with these new rules. And there was a lot of complaining in Texas and elsewhere that state governments were not getting enough detail to actually know what to implement. You know, some of that have been true, but some states were more assertive than Texas in getting a plan. They thought about it, they made a plan, and they intended to act. But all this given an extra 3 years, and so therefore that would be March of this coming year, where states are not supposed to be still planning how to make these services more integrated and self-determined, but really how to be completely compliant with it. And as far as I know, sitting right here with you all right now, I have not been able to see that Texas has a plan that is approved. We've had several iterations of plans, and the most recent one, and I'm going to give y'all a link to that later, was back in 2019. But our plan has not been approved that I know of sitting here, and I did do some recent research. Anyway, what does the rule want? The rule wants to say that the waiver programs and the other Medicaid funding programs, like maybe attendant services that are not in the waiver for people that are waiting for waivers or don't have waivers, that those should be integrated in and help provide full access to the greater community. So you'll hear this term now, in addition to the new term, home and community-based services, the greater community. It's a conceptual framework so that if you get funded for a Medicaid program and it's a community program, that you really get to access the community that you live in. And you might be doing things in the community and there is support for not doing things in the community that are more integrated, not just limited to people with disabilities. So when we talk about greater community, that's what we mean. Maybe the person wants to go to the rodeo, or maybe the person wants to go to the Friday night football game, and maybe they get Medicaid funded services. But because the program's rigid and not everybody wants to go, and all kinds of reasons why the schedule doesn't work because somebody has to come home and take medicine at a certain time, people don't really get to have independence in making life choices like that. So these rules were to improve that. And then there are residential and non-residential settings that are not only for people with disabilities, but for people in the general community doing things that they enjoy doing. And so this is a nudge or a push to make those more available through the funding from the federal government. And also there's a lot of lip service about the right to privacy, dignity, respect, and freedom, and also free from restraint and coercion. But I think that these rules are an effort to really make those a reality, not just words on the page. And also work is a part of it to help people get real jobs in the community, competitive jobs that pay at least a minimum wage. So that's definitely part of it. And just to choose where they want to live, their own unit or bedroom in the place where they live, which sometimes is referred to as a residential setting. In Texas, you get this long list, and it's like, here you get to choose your provider, and then you're not going to a very good process that really helps you match up with the place you want to live, the people you want to live with, close to the things in the community that you want to be close to. It's pretty limited to, here's the list, pick a place and see if they have any vacancies. So it's a pushback against the sort of where is the vacant bed mentality. And I know that there's a lot of people up in North Texas that are doing a lot of work around this on housing and regular housing in the community and housing where people want to live. So it's far beyond just a choice of providers and services. It's really, how do you want your daily life to be? So recently in the federal government, there's so many different acts out there right now, but here it is, the American Rescue Plan Act offered an incentive to states, and the states could decide to enhance their home and community-based services by getting an extra 10% contribution called FMAP from the federal government to pay for the services. So this is a recent development, and we advocates around Austin, and probably a lot of y'all too, kept wondering, well, is the state even going to apply? And then finally we found out that the state did in fact apply in July, just last month, and submitted a spending plan that's supposed to help facilitate some of these changes. So there's a link to the actual plan. It's only 10 pages. So if you're interested in that, you can see what Texas submitted. I don't believe we've heard back in terms of approval for that. But there was concern that Texas might not even do it. Texas tends to be highly sensitive to if they get money from the federal government, are they locked in for life? Is it a lifelong commitment, or is it a short-term commitment? Is it flexible? So I think a lot of that went into Texas spending plan to improve home and community-based services. But and I'll give you some details of that in a minute. But the letter that Texas sent and the plan that they sent for consideration did have a lot of criteria, and they said, we'd like to submit this plan if the federal government can meet these certain criteria. So the state needs to know, like, are these, long-term sustainable commitments that we're making? Is it our ability to just infuse some one-time short-term money that could be available? And by the way, it has to be spent in a pretty short time frame. So that did affect what the state has just last month proposed to do. So that was a clarification that's mentioned down here in the last bullet about what Texas needs to even move forward. So what's the plan? Well, it has three parts, or three broad goals. One is called supporting providers in the workforce. One is supporting recipients. And one is enhancing and strengthening Texas infrastructure for the services. So I'll show you some calculations that HHSC, the Health and Human Services Commission, made to see how much money they should have and what they might do with it. So again, it's a 10% additional federal contribution to these three goals. Here's how it plays out. So they said that they wanted to do the following for provider and workforce support. So everybody knows, I'm going to even say probably everybody on this call knows, that it's really hard to hire and keep a support person, even if you have access to community services. So there's been a lot of advocacy year after year to just increase the rate that attendants and direct support professionals get. And again, that's a sensitive area for the state because it's a long-term commitment, and those who would receive it there's a lot of people. So it is a big investment in our state in community services. It certainly is one that other states make, and that Texas could take advantage of lots of opportunities, but they also need appropriations from the legislature to deal with the workforce issues. So what would happen if we get approved is there would be some sort of bonuses and paid time off for direct care workforce. And that would be when they say it's for fee-for-service and managed care programs, but you see it has to be spent by the end of 2022, which is not a lot of time. I don't have the details about who would get how much for these temporary bonuses, or maybe some sick leave, something like that. But when they say fee for service, that means because the class Medicaid waiver, the HCS Medicaid waiver, the deaf-blind Medicaid waiver, the Texas Home Living Medicaid waiver, all of those are only in managed care for like their acute care or medical services. The waiver services are not in managed care, so those are described as in fee for service. And then in managed care, we have STAR Plus, home and community-based services. We also have medically dependent children program services. And when I was looking at the transition plan, there was also a reference to the adult mental health home and community-based services. So I don't know exactly what's going to happen with this, but rather than raising wages long-term or providing a time off for sick leave or anything else, these will be short-term infusions of money. And the total amount is 181 generally million in state money. Then that draws down more federal money. So in the short term, it's extremely helpful. Does it take care of everything? No. One of the things I've noticed through the years is when there is a money that's available, extra federal money that's available to the state, it's very popular that the state likes to use it for their internet, their IT, you know, so that is included here, and it's a little over $2 million. And what has happened with all the agencies kind of being under the umbrella of the Health and Human Services Commission, there are some of the systems, the internet systems, the technology systems that don't speak to each other. So part of it could go to that, but part of it is to have a long-term care portal where some of the work can happen, and different entities within state government can communicate better, but also there can be some help for families and individuals to be able to look up more information online or communicate with the commission online. And a little bit of money for critical functionality for service delivery. I honestly don't quite know exactly what that is, but I have participated in a lot of advisory groups, and there are lots of gaps in services for people with disabilities, particularly people with intellectual and developmental disabilities. And I think that some funding now is being made available for people with high medical needs in some situations, and I don't recall if that was part of that or not. So then here's another goal, was the recipient support. Okay, there is day habilitation that is in several of the programs, or sometimes it's called pre-vocational. And from the beginning in 2014, when these rules came out, there was a hope that we would either drastically change that program so people could have a more meaningful day and spend time in the community according to their preferences. And I can't tell you how long, really starting in 2014, various advisory committees have talked about this. And what most people wanted, there was some consideration of not having any day have at all going forward. That it's really facility based and people don't get out and about into the community. So why are we using these community dollars for that? But there were other voices that said, no, you know, we need that full-time for some people. We need it at least part-time for some people. So if a person's working part-time, it may not be full-time. They may be wanting to go to a program, and that program could itself be more integrated. It could be a place you go, but then in the course of the week, you might be going out into the community from that site. So This money here, the 35 million, is a very small incremental step. Because the other thing advocates wanted is to have a pure option for not going to day half, but having support for your meaningful day for the hours that you would have been at day half. And that is, it always gets pushed to the back burner. So it's not that the state is saying in our transition plan they would never get there, but the first thing that they had proposed and the legislature authorized, and now they're going to use this funding stream for, is to so-called improve DAHAB. They've named it badly, ISS, Individualized Skills and Socialization. If you've ever had a kid in school, you know that that's not a good term, as you got sent to ISS if you were in trouble in the classroom. So maybe the name will change, maybe it won't. But in order for people to show up at a DAHAB site and get to do more in the community and get to have a say, self-determination, and what those kind of things would be and who would be going, there has to be enough staff support. So what I'm hearing from providers is that this funding doesn't match up with the recommendations for staffing, and the staffing was going to be based on the level of support a person needed in the community, which might be even more, at least at first, than they need in the facility. Because maybe they're going into new environments, maybe they have some sensory issues and they're just going to need a little extra help to acclimate to that, or maybe it's long term. So this 35 million is taking a incremental small step to improve the site-based DAHAB and incorporate some community activities in that. And then the next bullet is money to provide waiver services to fund additional slots. This was a bit of a confusing thing when we saw it, because this was the same amount of money that the state, we felt, got authorized from the legislature to fund. So there's Medicaid waivers, and each of those has a number of waiver so-called slots, so people could get off the interest list. Well, in reading the plan, you can see that the state, I think, had the authority to do that. It seemed like they were just supplementing what the legislature provided. We were so excited, we thought, wow, we're going to get more waiver slots. But no, this just funds those waiver slots that the legislature authorized, and it's a timing issue. So that the funding, this initiative, was based on funding that you had as of April of this past year. And since the legislature hadn't officially funded them until the end of May, then you could argue, I guess, that it wasn't supplanting what the legislature funded. We would have hoped that these would all be in addition to what the legislature authorized. So there's a bit of confusion over that, but hope that this money would have gone further. Again, people that get these waivers generally stay on them long term, and the state didn't necessarily want to make a long-term commitment like that. Some of us had been working on a pilot program because it was several different pilot programs. And so one had to do with outpatient mental health services for individuals who are at risk of institutionalization. And then another one that we've been working on has to do with if people, a pilot program before any of these Medicaid waivers that serve people with intellectual and developmental disabilities might merge into managed care. So before they would be put in managed care, the idea is let's just try some things in one area of the state and see if it would work or not. Then make a decision about that. So anyway, there's some movement on that as well with funding. So the other big thing that came out of the legislature was people on the interest list, there's not a lot of information known about them. And the legislature, sometimes they think like the need isn't real, the people aren't real, various things that make the interest list seem like not worthwhile funding. And so to overcome that, one of the things that happened, and I'll talk a little bit more about the bill in a minute, but there was some money to find out a little bit more about people waiting for services. It's a questionnaire. And also, sometimes while people are waiting for a comprehensive Medicaid waiver program, there are other services that they could access meanwhile. And so there is an effort to find out a little bit more about what they need and also what they could be accessing now. So that's what that $6.5 million amount is for. Here's the other pilot program I was talking about, and it's $5 million for that. And again, it's back, if you just see here, it has to do with automation that's needed to even start to build out the pilot program. It has nothing to do yet with all the services that would be added to the pilot program. And, the pilot program, if it actually gets funded, that will be next legislative session, a couple of years from now. And it's going to take a lot of money. So the first step is IT systems changes, and that's what that is for. And then if we have home and community-based services, and they're supposed to do more for self-determination and let people have choice, we're going to have to be changing some policies and some rules, and then have to monitor, whether or not people are getting more integrated into the community. So this next item has to do with monitoring compliance, not just at day hubs, but at residential settings as well, to ensure that people are getting more choice and control over their schedules and things like that. And then, of course, I'll have project management. They'll have an evaluation expense and things like that. So these slides here, if you have ideas, you can still click on this mailbox and submit them. But these kind of add up to the money. First, I'm going to go to the next slide first. So if you take these big dollar amounts about what the state was going to invest in for waiver services, and even in managed care and in fee for service, it comes out to $2,869,000, etc. And if they get the federal government to contribute 10% to that, the 10% is $286 million. So where do you see the $286 million? It goes back into the three goals, and it totals $286 million in general revenue or state dollars. It will draw down more federal dollars. So anyway, that was kind of how the math worked. But also, HHSC, I believe, is still taking input or questions or recommendations regarding this spending. You can give them a thumbs up or a thumbs down, say that you would like to see them do it differently. They haven't been approved yet. So stakeholder input. When I look back at the plan, I could see what Texas is able to justify since 2014 in terms of how they listen to stakeholders. In comparison, Colorado, when they realized they could get this extra 10% of the funds, they had hundreds of meetings or talked to hundreds of people in meetings all around the state, as well as they had just an online survey and people gave input in terms of what they would like to see the money go to. In Wisconsin, they used some of the money to eliminate the adult waiting list. Wouldn't that be awesome? Eliminate the adult waiting list. And then also focusing on health disparities, which is important. And that includes various kinds of disparities, people with varying abilities, people living in rural areas, different ethnicities, and other underserved, disadvantaged communities. So what Texas did, all this time, all these years, they would have some webinars where they were informing about this initiative and what Texas was going to do to comply in the first 5 years. Remember, it was 5 years at first. They had meetings. I was in some of those. They had advisory committees, work groups, provider conferences. They did electronic notices and got some feedback that way. They did surveys and they surveyed participants and providers. Now, the surveys are really important here because in the surveys, they were asking providers, are you compliant with these guidelines that the federal government has put out? And then they asked participants the same question. And some of the things that helped kind of align the focus would be, oh, if participants and providers were saying, wait, Emily, we're saying the same thing, then whatever the response was right, or at least close to it. But if the providers were surveyed and they said, yes, we let everybody have the food they want to have and the schedule they want to have, and they don't have to go to bed at a certain time, and yes, we take them into the community. But the participants said, no, we never get to go. We don't get transportation, you know, and if it didn't match up closely enough, then that became something that needed to have remediation. And so there were sometimes that the survey said, well, yeah, they're both the same, and they're both showing that we're out of compliance. We are not getting people into the general community. But even if the provider said, yes, we are, and the participants said, no, we're not, then that was going to be an area needing correction. So there was a lot of work, lots of work done up front to kind of figure out internally and externally, where are we with supporting people to have self-determination and using these dollars accordingly? Where are we with that? And what do we need to remediate? And there was a sorting out between residential and non-residential like they have. But like I say here, HHSC still invites stakeholder input. This slide, how am I doing on time, Cindy? Okay. I can't hear you.
You're doing good. It's only 6:45. We've got 45 minutes.
Okay, great. So this slide here was a puzzle to me because I couldn't figure out in the whole set of slides where it fit best. So I just finally left it here. I want to talk about this because it's another opportunity to try to get at making sure we have a workforce that can really do more to support people to live the life they choose in the community. And this is in Congress. It's called a Better Care, Better Jobs Act. Now, when they first proposed it in Congress, it seemed very robust and like wonderful, something that would help our state and other states so much. And as will happen with any kind of proposal, there will be negotiations and compromises. And what it says it would do on this slide certainly has by this time been shrank a little bit. It might not be as much money available, so it might not be quite that robust, but it's not off the table. I think there's a lot of interest in this. Also, this really helps us in the aging community. So many more people are aging. People who are aging certainly are wanting to remain in the home and in the community. And that's going to help us because I think we're on the same page with that large demographic. But it would put billions with a B in Medicaid to strengthen the infrastructure, pay people better, maybe provide some benefits, and also strengthen and invest in more access. So access for improving the workforce, access for not being on long waiting lists. And then also, well, here it is kind of the same thing where it's talking about older adults and people with disabilities from low income households. As you know, some of them don't have family support. So some people with disabilities don't have family support. So how do we really make sure that there's enough support and dependable support so that people can actually avoid unnecessary institutionalization? So what that might do is increase financial eligibility limits and provide enough funding so that that would increase the people that have access by 3.2 million. Wouldn't that be awesome? So awesome. And if that got funded, that would create a lot of new jobs for direct care workers because you would have more people who have a funding source and enable family caregivers like many of us to be able to work. So it really tries to flip the institutional bias and focus more on community and build that up so people aren't having to wait for services. This guy, I love the picture of this guy. I hope y'all can see it, but it's like, I'm waiting so long, I'm so bored, I'm just sitting here waiting. But he's waiting because Medicaid is the main way that we cover these community services, but it's been underfunded, and I think Texas is one of the worst for decades and does not have the capacity to serve everyone who needs it. When I say Texas is one of the worst, where do I get that? I get that from some of the national reports from the United Cerebral Palsy and others, and they rank the states, and you can see that Texas is like at the bottom or near the bottom in this particular variable. We spend less per capita on people in particular with developmental and intellectual disabilities as compared to other states. And so it's not like Texas doesn't have money. And right now, because of all that COVID money, it's really hard to see why the state didn't go further on funding long-term investing in these waiver slots. But right now, you know, we still don't have the capacity to serve everyone. And that's what some of these initiatives are trying to get at. So nationally, we have 800,000 people on interest list or waiting list. We have a large percentage of those. Not some, not all are waiting for 15 years. If there is anybody in this meeting that is not on the interest list for some of these programs, please reach out to Cindy or myself and we'll help you get on the interest list. And there is some limited ways for people who are in crisis or who have medical complications, or maybe they lost their caregiver, even get on the waiting list, or even if they're not on the waiting list, to get access to Medicaid comprehensive waivers sooner to avoid institutional placement. So, you know, that's another presentation altogether, I think, but I can talk about it at the end if we have time and y'all are interested. So this is something, this next slide that we got from the numbers from the state. And these numbers here all reflect people coming off the interest list. There are other people who were generally funded for a number of years, and it was called Promoting Independence, Transition, and Diversion Waivers. In other words, it's Medicaid, but it's more comprehensive Medicaid to cover people so that they can avoid unnecessary institutionalization, or if they're in, they can get out. For the last two legislative sessions, the state did not provide designated funding for this group, and they are using a process where when a person vacates a waiver slot because they die or move out of state, something like that, then they will use those waiver slots for transitioning to get out and back into the community or to avoid going in. And that is a very problematic in our view at Disability Rights Texas situation, because when we have different and more robust processes, more people, many more people were getting out of institutions and diverting from going into institutions than those vacant slots would allow. And I think sometimes if you have like a certain funding and it's reduced, then the effort's reduced. And so, you know, it's kind of a cycle. So now it looks like maybe we don't need that much funding for them. We can just use these vacant slots. I would strongly disagree with that. So I think we need to get back to robust processes and having designated slots. Meanwhile, the numbers that you see for end of biennium in this last row are exactly the numbers that are in the HCBS transition plan. These don't add up, by the way, across the rows. It's the last column that is likely to be the right number. That is the number that HHSC has provided so far. So you can see that we have a lot of work to do on getting people into services. So a big thing happened I thought y'all might be interested in. And last time, Cindy, when I did a presentation when we got to meet in person, I did talk about the home and community-based services, but also a little intersection of that with the waiting list. So two big bills were filed that have to do with or relate to the interest list. They call it interest list, I call it waiting list. The first one is House Bill 2658. And so you will see that the kind of good news here, I think, is that a lot of us are on an advisory committee. It's called the Intellectual and Developmental Disability System Redesign Advisory Committee. And that committee's been in place for a number of years now, and it has a variety of stakeholders on there: providers, advocates, self-advocates, family members, managed care companies, etc. So when there was a bill filed that was, you know, a little bit concerning about what we're going to do with the waiting list, one thing that the author agreed to was that if we're making changes to it, let's make sure that there's a stakeholder group that's involved in it. So a couple of years ago, there was a study about what Texas should do to eliminate or reduce the waiting list and get people in services. And that advisory group was involved in that as well, although HHSC produced the report and the advisory committee's recommendations are at the end of the report. So one of the recommendations was, well, it would be good if people are on a waiting list to let them be able to communicate with HHSC online. People have a change of address, their name comes up on the list, you're at the top of the list, they can't find you, and therefore you don't get your waiver that you've waited for 15 years. So that was just one kind of creative idea. It was like, okay, let's just do an online portal and people can check where they are on the list, and they in multiple lists, and they can also do a change of address and things like that. So it became a question of, well, that's going to cost money. And so the study of it was going to be, is it feasible and cost effective to do this, you know, portal where people can communicate with HHSC? And what happened was when we reviewed this a couple of years ago, we had looked at a lot of other states and there were some bad outcomes from them changing the way they do the interest list. In our state, we have first come, first serve. so you can get to the top of the list because you've been on it so long. We also have these crisis pathways to get the waiver that I mentioned earlier. And so we have kind of a hybrid system. And what we had wanted and what the state had done, the legislature had done, is they had funded some for people on the interest list and some for the people who couldn't wait, that were at risk of institutionalization. So some states did a redo of their list. And if you did not show that you were the most critical in need, they actually took you off the list. We were very alarmed. We did not want Texas to do that. Imagine having waited, a long time, and now there's an assessment, and the assessment says, yeah, either we're going to move you down the list, or, get back with us when your need is more urgent. So I think that this bill did not take that really scary next step, but they will use the questionnaire to determine things like, you can tell me if you're concerned about losing caregiver support, or what kind of services are you looking for. The new questionnaire is not developed. There will be stakeholder input on that, and I'm sure some of y'all will be willing to help us look at that. But we were worried too about, well, what about people who can't use an online portal on their phone and don't have a computer, don't have internet? And so the bill author came up with the idea that you could use an ombudsman to help you update your contact information. So literally people, even there are people that are supposedly on the waiver and cannot be located when their name comes up. But there are people also who get a waiver slot offered to them and they cannot be found. And that happens mostly with the class Medicaid waiver program because they don't have these IT systems. They're not automated, and it has historically been more paper, more manual. So, and people move. I've been very worried about people moving, having to move because of COVID and getting lost. So this other bill, House Bill 3720, again involves a stakeholder advisory committee, specifically in developing this questionnaire. And if a person can't be located, there's a lot of the programs, they want to contact you once a year, and when they do, respond. Please respond. You have to say, yes, we're interested still. But sometimes people don't. So instead of erasing them, if they don't respond to a written or verbal annual contact, they just get moved to another column of inactive status. And the inactive status does not let anybody get the pencil out and erase your name. What it does do is keep a record of you. So at some point in time, you might say, I had to move in with my grandparents because of COVID and somebody got sick, or I lost a caregiver, we lost contact, but here I am, tell me where I am on the list. And they would say, well, you're inactive. They can move you back to active status, and we'll move you back to active status when they know that you still are needing and seeking services. You do not go to the bottom of the list. You actually keep your date at which you got on the list. So part of this is just optics, the visual. So the state, advocates within the legislature that want to get more funding for the interest list, they have a hard time if people get to the top of the interest list and it looks like they're not eligible or they can't find people. So they want to, I think one of their goals is that they want to show that the list is real, that people really are alive, they're there, they need services. And so they want to move the people on the inactive status a little bit further out of the view of reporting. So we said, well, we want to know if people are in inactive status, and so they got to report the data to somebody so we could see, for instance, well, all these people that moved to inactive, they were in the Houston area and there was a hurricane. So we need to find the people. You know, it wasn't a situation that we imagined where they were not trying to stay in contact. It could be any number of reasons where they weren't able to maintain contact. So we just wanted to make sure that whatever happened, if a person got moved to inactive status, that they could get right back in line at the correct point in time. And that the inactives, we could at least look at that and see what are the trends. Was it all rural areas? They don't have access to internet, so they can't update their, their contact information. Do you still have an 800 number they can call to update their information or answer the questionnaire? So this is going to be pretty new. It's not immediate, but it will be something that you will see in the future. And so it's self-reporting at this point. It's not that we're going to do a test on you. We're going to say, if you're a level of need 9, you get in now. If you're a level of need 1, we're going to take you off the interest list. So anyway, there'll be lots of opportunity for stakeholder input, but this is a pretty big deal. It's relating to whether the state can actually move people into and have access to home and community-based services. So that was pretty long-winded. Here is how you can reach me, and also how you can apply online for our services if you need assistance with a number of different issue areas. Could be Medicaid, it could be special education, something related to employment, housing discrimination, and there's you can get on our website and also do an online request for assistance, apply by phone, or if somebody needs sign language video, we have that as well. So, Cindy, I'm going to turn it back over to you, and I'd be happy to take questions. We can't hear you yet, Cindy.